Hello, and welcome to Take Charge of Your Cancer Risk. Learn what your genes can tell you. Our webinar today is hosted by The Insiders in partnership with Susan G. Komen. I'm Erin, Executive Vice President and Moderator at Sommer Consulting, the parent company of The Insiders. And today we'll be learning about genetic cancer risk and exploring next steps for discussing genetic testing with your doctor. So let's meet our amazing panel. We're joined today by Ange Otto and Asha Miller, two third-generation breast cancer survivors and patient advocates. Dr. Tua Pal, clinical cancer geneticist, Komen Scholar, and Associate Director of Clinical Genomics at Vanderbilt Ingram Cancer Center, and Nikki Delva, a certified cancer genetic counselor at Mount Sinai Hospital. So now why don't each of you take a moment to introduce yourself? And Ange, why don't you start us off?
Sure. Thanks so much for having me. I'm really excited to be here. As Erin mentioned, my name is Ange Otto, and I am a third generation breast cancer survivor and patient advocate. I was diagnosed in October of 2022, and since then have been really empowered to share my story, especially for people in the minority community.
Hello, I'm Asha Miller, and I am a breast cancer patient advocate. And similar to Ange, I really am passionate about the Black and Brown breast cancer community. There's been three generations as well over here that I know of with breast and gynecological cancer, and I am just so honored to be here.
Hi, everyone. It's a pleasure to be here today. My name is Veronique Nikki Delva. I'm a cancer genetic counselor in New York City, and I've been doing cancer genetics for the past 4 years. I'm also very passionate about increasing access and care to genetic counseling and genetic testing in the community.
Hi, thank you so much for having me. I am really honored to be here. I'm a clinical cancer geneticist at the Vanderbilt Ingram Cancer Center, where I see patients at high risk for inherited cancer, but also manage them over time for cancer risk management. And I also do research focused on inherited cancer predisposition, spanning from basic science to care delivery.
Well, welcome all, and we're so thrilled to have you as our part of our panel today. As we're going to get into our first topic, we'd really like to just talk about genetic testing in general. So let's start with the very basics of genetic testing. Nikki, maybe you would like to start us off, and maybe you could just tell us, what is genetic testing and what does the process look like?
Yeah, so genetic testing looks at our DNA, which is essentially the instruction manual for our cells. Specifically in the world of cancer genetics, we're looking for different inherited changes that can increase somebody's risk to develop cancer over the course of their lifetime. So these are differences that someone is born with and can be passed on to their children and can impact their siblings or their parents. To be specific, we're not really testing to see whether or not somebody actually has cancer. More so, we're trying to get a better understanding of their risk. If they have a strong family history of cancer, we're looking to see if that person might also be at an elevated risk. And if someone already has a diagnosis of cancer, we're looking to find an explanation for their diagnosis. So the actual process of genetic testing is usually someone is referred to a genetics professional where they'll then meet and discuss their personal medical history and family history, which is really important. And then we'll kind of discuss what sort of testing might be most impactful or helpful at that time. Then the actual genetic testing is ordered, and usually there's a follow-up process where we talk about those results and next steps and what that might actually mean for the patient as well as their family members.
What kind of samples are needed?
Yeah, so we use a variety of different types of samples. It's usually a non-invasive process. Most commonly, we use blood, but we can also use saliva as well as, in some cases, we can do a buccal swab. So just like a simple cheek swab as well.
How long do the results typically take?
Yeah, so results generally take around 3 to 4 weeks to get back. It does depend on what lab, but generally we kind of quote a 3 to 4 week time span. In some cases, we can also order more expedited testing using what we call a stat panel. That's usually used for surgical decision making or other sort of urgent decision making, where that would come back much quicker. And we could also use that to help decide sort of next steps for planning with treatment.
So, Ange and Asha, I know both of you are third generation cancer survivors. Maybe, Asha, you could start us off and tell us a little bit about what your experience was like with genetic testing. Is there anything that surprised you about the process?
Yeah, that's a great question. So for me, I think the most surprising was learning my family history. When I went in first for genetic testing, I didn't know that I actually had a family history of breast cancer at the time. I think that's very typical in Black and Brown communities. And so I think for me, the thing also that surprised me was how emotional it was. It was a lot heavier because I was thinking of my kids, especially. I'm a mom of two, and especially my daughter. I thought, is she at a higher risk with me having a genetic predisposition? I was diagnosed more with a VUS, which is called a variant of uncertain significance. So it was confusing at first because it wasn't a clear like positive or negative. It was more we think that there's something unusual, but check back in about 5 years. If things change, we may have more information. And so that was something I feel like that was the most surprising. I thought it was going to be very cut and dry, and it wasn't.
And how about you? Could you tell us a little bit about your experience with genetic testing? And again, was there anything that surprised you about the process?
Yeah, well, what's different for me is that when I did genetic testing, there were no genetic markers, and that actually was a surprise to me because I knew my family history before I was diagnosed. In fact, that's how I was able to get diagnosed at an earlier stage is I qualified for mammograms shortly after turning the age of 30. So I knew that my mom had breast cancer, her mom had breast cancer, and I was convinced that when I did genetic testing, surely there would be something that would explain the pattern that we were seeing in my family. But after we got the results, there were no markers. And I think that was, in some ways, it was a mental impact on me because then I began to wonder, okay, well, if there is no genetic marker, at least that we know right now of, what did cause my cancer? I think that's something that a lot of people go through when they're initially diagnosed, is they're asking why, how did this happen? And over time, I think you realize that sometimes these things, they do just simply happen. I think that's why I continue to be a big proponent of genetic testing, is because I truly believe that perhaps one day there will be a genetic marker that I'll test positive for, but we really need to make sure that we're being consistent with retesting so that we have more of that information and knowledge.
And Dr. Pell, from a clinician's perspective, what are the benefits of genetic testing and how has it evolved to inform treatment?
So the benefits of genetic testing, again, in the unaffected setting. So say someone has a cancer diagnosis and they are found to have a specific mutation in a predisposing gene. That gives their family members the opportunity to be tested early and prior to getting any sort of cancer diagnosis, right? That's the thing. It can identify unaffected people before they develop cancer to either prevent cancer or detect it much earlier. So, those are some of the benefits. In the treatment setting, like you just asked, there are targeted treatments. And what I mean by that is, for example, with if a woman has breast cancer and a BRCA mutation, she may qualify for certain drugs that are targeted to her specific cancer from like being a BRCA associated cancer. So that's where I do think there are advantages. So even in the like in the context of having a diagnosis of breast cancer, sometimes one of the misnomers is, oh, well, I've already had a diagnosis. Why do I need testing now? And the thing is, beyond the treatment relevance, it's also future risk, right? So we think of inherited breast cancer genes being BRCA1, BRCA2. Well, they could be called inherited ovarian cancer genes or inherited pancreatic cancer genes, right? So there is a spectrum of cancers that go along with each of these genes that isn't often just associated with one cancer type. So there are ways of being proactive beyond just having, a breast cancer diagnosis. The other thing is, for example, if someone has a BRCA mutation and breast cancer, the chance of developing a future breast cancer, again, could be much higher for them, especially if they're diagnosed at an earlier age. So there are things that we would want to do to continue high-risk screening or preventive surgery. So I think there are a lot of implications to knowing about this test.
Thank you. And let's continue on that topic of family history. We often see family history split by gender, but of course, inherited mutations can link cancers across genders. So, for example, prostate cancer is genetically linked to breast, ovarian, and other cancers. So, Dr. Powell, how does a patient's family health history influence the genetic testing physicians order or recommend for patients?
So we have specific guidelines that are based on personal and family cancer history. So as part of the risk assessment, we would take a complete personal and family history to figure out, are they eligible for testing? Now, what I'll say is, if you are eligible per National Comprehensive Cancer Network or NCCN guidelines, generally it is paid for by your insurance. That's not an absolute, but that's kind of a general guideline. That being said, genetic testing, we think of it as costing thousands of dollars. And nowadays, you can actually get testing for a few hundred, which again, is still a lot of money, but not in the thousands. We're talking in the hundreds. So I think there are ways of getting testing now that weren't accessible, say, a decade ago.
And are there any family health history patterns that signal more evaluation is needed?
So we always look at age at diagnosis, type of cancer, and the pattern of cancer, right? So all of those things in conjunction are what we would look at to see if someone was eligible. Now, you made a really great point about family history and maternal versus paternal side. And I think many of us who've practiced for a long time have seen this, where there is this misconception that, oh, breast cancer, it only matters on the mother's side of the family. Like you can't inherit it from your father's. And that is just not true. And even at the healthcare provider level, I mean, I'll just tell you, I saw a patient yesterday that I was seeing for cancer risk management for a BRCA2 mutation. And the way she got tested is she has two paternal aunts with breast cancer at an early age. Her dad is unaffected. And when they went to see the doctor was like, oh no, it's mom's side of the family. It doesn't matter. And so her mom, who is a judge, pushed it and said, that's not what I read, and took out articles. And that's how she got tested. And not surprisingly, she has the mutation, as does her dad. So I think that we need to do better increasing patient awareness, but we also need to increase provider knowledge. And even at a systems level, genetic testing is becoming a lot more accessible. Like, are there ways of searching electronic health records to be able to identify more people? And it is unfortunate because looking at family history, like if we were better with cascade testing, that's a fancy term for if someone has already been diagnosed with mutation cascading out to their family members. So getting more family members tested. So if we were better about being able to do that, I think we could test a lot more people. If we were better with family histories, we could find more people. And when we think of it big picture wise, the BRCA genes, as an example, were identified about 3 decades ago, right? In the early 90s. And our estimates are that of adult females in the United States, we've maybe identified 20% of these women. So 80% of people, or 80% of adult women with a BRCA mutation, do not know that they have a mutation. So again, I think there are many ways of approaching this, and we need to do better.
Nikki, what questions do you recommend people ask their family members before they seek a genetic counselor?
Yeah, so typically we recommend making sure to, just like Dr. Paul was mentioning, getting a better idea of the age of diagnosis, what sort of cancer types that we see in your family. You know, there are certain cancer types that we consider to be red flags or things that make us more suspicious compared to others. For instance, lung cancer is typically environmental, has a lower likelihood of having a genetic or hereditary explanation compared to maybe a male breast cancer in the family. That's very rare, and we don't see that often, and is largely associated with the BRCA mutation. So certain things that we might see in the family history might make us suspicious. For instance, in addition, like ovarian cancer, pancreatic cancer, more rare cancer types. If family members have had more than one cancer diagnosis, so breast and ovarian cancer, or stomach and colon cancer, those things would also raise our suspicion as well. So age of diagnosis, what sort of cancer types? Has anyone in the family had genetic testing at this point? If so, what type of genetic testing they've had? If they were positive for anything, if they were negative, those things are really the most helpful.
How many generations back should people try to collect that information?
Yeah, great question. Generally speaking, we take a 3-generation pedigree. So that would include yourself, your siblings, your parents, as well as your grandparents. And so we would take all that information, but also with the added context that if your mother is an only child and she had breast cancer, we put that into context to better understand risk as well. And same for paternal side of the family too. If there are less or more family members, if there are multiple cancers versus a lot, all of that is taken into context. But generally speaking, we like to get, your generation, your children, if any, your parents' generation, as well as grandparents. If there are additional cancer types too, that's also helpful to have.
So, and just as a patient advocate and someone who has gone through these types of discussions with their own family members, in reality, what do these conversations with your family look like as a patient? And do you recommend any strategies when talking with your family about their health history?
I think these conversations can be really tough for many people, especially so in minority communities where talking about things like cancer or how people have passed away is really uncomfortable and in some ways shunned on. You know, growing up in a very Asian community, cancer was not something that we talked about often. And when I myself was diagnosed, we went through a phase as a family where we wanted to keep that information to our immediate family. So I think talking about and learning about your family history can be quite a challenge. But I do think that the tide is starting to change. I think that as more young people get diagnosed, which unfortunately is happening more and more, especially in minority communities, I think we as patients want answers. And so that is a big motivator to starting to have these conversations. In terms of how to have them, I think my advice is to take it step by step. I think it can be overwhelming to go to your parent or a family member and say, okay, I need to know every single case of cancer in our family in the last couple of generations. I think that can be a really hard thing to ask someone, especially when that conversation is a little bit taboo. So I think easing into it, asking here or there, maybe incorporating it into just learning more about your family in general can sometimes help. And really just sharing that the more information we have, the more that we can understand how to better take care of ourselves and to take care of our future generations. That is a really big thing in my culture, certainly. I think for a lot of minority cultures is so much of what we do is to support our current and future generations. So if you can frame it under that perspective, then you really are putting the benefit over that discomfort that comes with that language.
So, what was your experience like in reality when you think about the conversations that you've had with your family? And again, any strategies that you would recommend based on your own personal experiences?
Yeah, I have to laugh a little bit just because it is awkward. I'm from a West Indian background, Afro-Caribbean background. And so, like Ange said, it was just not talked about so much so that I honestly didn't think I had a genetic history with cancer or anything until my mom was diagnosed with breast cancer 2 years after I was. Even to this day, I don't speak about it too much publicly because it's very private. There's a lot of, I wrote down, in the family, it's like deep trauma secrets. It's very embedded in the culture. And like Anne said, I think for me, it was getting to the heart of, hey, this is about taking care of the next generation. This is about taking care of the grandkids and making sure we're okay. I think that's helped, but to be honest, it's been hard. One of the biggest strategies I feel like I've used is consistency. I'm like, did you do your genetic testing yet? Do you remember what was it about grandma or auntie? What did she pass away from again? And I've gotten more information. That was how I got that my grandmother's sister, she also passed away from breast cancer. And I had no idea when I was diagnosed that it ran so deep in my family. A big part for me is just framing it around that it will help the next generation, that it will help your grandkids to be able to live healthier lives if we have this information. Um, the thing that I always remind people is that you may not get every answer, but even partial information is helpful.
Thinking about, especially with cultural disparities and some of the different barriers to genetic testing, research shows Black women are at a higher risk for BRCA mutations, triple negative breast cancer, and 40% more likely to die from breast cancer than white women. Programs like Komen's Worship in Pink and Stand for Her have brought genetic counseling directly to Black women in under-resourced communities. So I'd love to talk a little bit more about this from a patient perspective. Asha, as a patient advocate, what are some of the barriers that you've seen when speaking to your communities about genetic testing?
Yeah, that is a huge, huge thing in our communities. And I think for me, first and foremost is awareness. Like the education surrounding that, many of us, I myself, we don't know. And if you don't know, you can't do better. And then if our parents, if there's a lot of silence around this type of discussion, then even more so. The education is not even passed down through generations. A lot of us are first generation silence breakers, if I can say it like that. And I'm really proud of us. I think, first of all, it's awareness. And then the second is mistrust. There's so many in the Black and Brown communities and then under resourced communities that I remember thinking, any testing, what are you doing with my genes? Where you're questioning everything. You're not sure where it's going, who's going to use it because of the history in this country of, those types of, tests and things being abused, but not realizing there's so much more parameters and security that's around that it's a lot safer now when you go through a trusted source versus when you just give your your genetics away to a 23andMe, say. The other one is fear. I know that some people avoid it because there's a lot even in my family where it's like, if I don't know, then I don't have to worry about it. At the end of the day, there is a fear of like, if I know, then I have to do something about it. What do I do? How do I, what are the next steps? So I think education first and foremost is one of the biggest barriers. Educating on how to get genetic testing, even the thing of you can get genetic testing covered by insurance. It was something I had no idea about until years after I got genetic testing when my mom was diagnosed. And her doctor actually told her, you don't actually need to go get genetic testing done. You're good. And I was like, you absolutely will get genetic testing done. So I took her out of that hospital and brought her to where I was. And I'm like, please test her. And so she got a similar, but actually a little different result than I did. And so it's retesting, asking questions, checking back, to see if anything has changed. It's all about education. The more we know, the better we can advocate for ourselves and be able to change that needle a little bit more.
I think something that Asha and I are both really passionate about is connecting with people in our minority communities. So just knowing that this can be something that's a really difficult conversation for people. There are patient advocates here. There are people online that you can connect to, like the two of us. My door at least is, and I know Asha, feel like I can speak for you too, but our doors are always open. So if it's something that people just need a sounding board for or just want to talk through before approaching their family, I think sometimes that can be really helpful. Just knowing that you're not alone and that, there's a real life person who's been through it too, who can connect.
Yes, I concur with what Ange says. My door is open too.
What are some of the things that people should look out for when it comes to genetic testing?
Yeah, so first and foremost, I think it's really important that if you're looking to receive genetic testing, that you try to reach out to a genetic counselor or genetic professional that is well versed in genetic testing so that you're able to get the best and most accurate test possible. Genetic testing is offered in a variety of different settings, but it's important to make sure that you're in a clinical setting. I know nowadays there's a lot of direct to consumer testing from different sort of companies that offer some genetic testing that can provide some information about your risk. However, we know that those results are not actionable and not the most comprehensive test that we can offer. Oftentimes, we might get false positives or false negatives, and we want to make sure that we're getting accurate information so that we can use that in an appropriate way so that we can actually use this information to help inform care for yourself and other family members. So I think it's important to know who you're going to get the genetic testing and making sure that you're getting the best test possible. There's a website on the National Society of Genetic Counselors where you can find a genetic counselor. You just put in your zip code and you can find telehealth genetic counselors or in-person genetic counseling if people are interested in that. We also like to think about who's the best person to test. Ideally, when we think about genetics, we like to test those that are affected first. For instance, if your mother had breast cancer in her 30s, and she's still living, it'd be great if she went to do genetic testing first because she'd be the most informative. If she had negative genetic test results and there's no additional family history beyond that, then we wouldn't necessarily need genetic testing for you. However, if she has positive results indicating that there's a genetic explanation for why she got her cancer, then we know that you would then be at that 50% risk to develop cancer. And we can do targeted testing to kind of figure out whether or not you inherited that mutation or not, and so on and so forth.
So I completely agree with what Nikki said. And thinking about, well, say someone unaffected gets tested first, right? Then you don't know, like if they test negative, whether they're a true negative, meaning the person with cancer in their family is positive, they didn't inherit it, versus the person with cancer wouldn't have tested positive anyways because we don't know what caused that. But we also realize all families are unique. So in some families, it's possible to test the affected family member, and others is not. I don't think we should withhold the testing because we can't get the affected family member by the same token. The other thing I was going to mention again, expanding on some of the stuff that Nikki just talked about, for example, with 23andMe, some people think that BRCA test, like you get testing is part of 23andMe. The thing is, you get, if we're thinking about BRCA1 and BRCA2 as two big sets of encyclopedias, you get a few spelling mistakes when there are thousands of spelling mistakes. So you are not getting BRCA testing. And especially when we're talking about, diverse communities. So minority populations, you're not getting the testing that you need through 23andMe. So that's where there is a little bit of a misnomer. When you see, the Ashkenazi Jewish population has a higher frequency of BRCA1 and BRCA2 mutations, and those are some of the mutations that are included in the 23andMe panel. So you get a positive there, yeah, that's important, and you should get it confirmed through additional testing. But if you get a negative, that is not good enough in terms of thinking that you've had BRCA testing or inherited predisposition testing.
Also, just to add to that as well, thinking about having a positive result from 23andMe, again, it just emphasizes it's not actionable. You would still need, according to the FDA, you would still need follow-up testing to do anything about that BRCA mutation anyway. So it's important, again, to really just kind of go to the source, meet with a genetic counselor or geneticist or genetic professional in general to get accurate and good comprehensive testing.
Many people think that genetic testing is extremely expensive, so they often avoid looking into it perhaps because of the cost. So, Nikki, could you tell us just a little bit about the practicalities? Are there other resources available to help decrease any of that cost barrier?
Yeah. So, if there are certain criteria that has to be met in order for insurance to really be incentivized to cover genetic testing, just like Dr. Powell was mentioning earlier, there's this thing called NCCN criteria, where if you have a certain personal history or family history, then insurance is likely to cover your genetic testing. It's never a 100% chance, but we hope that they'll cover your testing or they're more likely to cover it. Testing is far more accessible than what it used to be. Like 10 to 15 years ago, when BRCA testing initially came out, testing was in the thousands for maybe just 2 genes. Whereas now, really, the standard of care is panel testing, which is where we look at multiple genes based off someone's personal or family history to see if they're at an elevated risk. And typically, testing is capped. They do have self-pay pricing that can typically be capped depending on what lab, but some labs, again, like Dr. Powell was mentioning, can be $100, can be $200 for different insurance plans like Medicaid and Medicare. If you do meet genetic testing criteria, oftentimes there's no cost to the patient at all. Other labs also offer different patient assistance programs based off somebody's annual income. So there are a lot of different ways that we have tried to make genetic testing a lot more affordable than what it used to be and far more accessible. Payment plans are available, so we hope that cost is not a barrier, although sometimes it still is, but we try to work things around to try to see if we can get testing at a lower cost for patients.
We've used the term VUS genes throughout our discussion tonight. Nikki, maybe you can just explain what that means.
Yeah, so whenever we do genetic testing, we can get three different results back. So you can get a positive result back, which means that we did find a harmful mutation in one of these genes that's putting you at an elevated risk to develop cancer. For the majority of these cancer genes, it doesn't put you at 100% risk to develop cancer, and it doesn't mean that you have cancer today, it just means that your risk is elevated compared to the general population. And for the majority of these genes, we have pretty detailed screening guidelines as to what we should do about it, whether that's surgical intervention, high risk screening, etc. Whenever we have a positive result, we recommend cascade testing and referrals to other providers. Second result that we can get back is a negative, which means that based off what we know now in the world of genetics, we didn't find any harmful mutations in any of these genes to either explain your diagnosis of cancer or to put you at a significantly elevated risk to develop cancer. When we think about all the causes of cancer, most of the time cancer just happens sporadically or by chance. So due to environmental factors and not due to inherited factor, something being passed down from your parents. So a negative result doesn't mean that you'll also never get cancer. Again, people can have a very significant family history of cancer, like in the case of Asha and Anj, but still have negative genetic test results. And so we typically monitor based off family history or other factors as well if they have a personal diagnosis. And then lastly, kind of the question mark result is a variant of uncertain significance, which just means that we did also find a mutation in a gene, but we're not entirely sure what that mutation means. Not all mutations are harmful. Oftentimes, they're just benign variation and things that make us unique in who we are. They don't actually alter the function of the gene or put you at a higher risk to develop cancer. And in most cases of those variants of uncertain significances, they're not actionable. So we usually don't change your management. We wouldn't change treatment options. We wouldn't need to test other family members. We kind of just wait to see what happens. Sometimes a variant of uncertain significance is reclassified in a few months. Sometimes it's reclassified in a few years, which is why we say to check in every few years or so, because it really does just depend. As more people get tested, we're able to see more people with that particular variant of uncertain significance and gather more data to determine whether or not this is a harmful change or maybe just like a benign change. And so those are really the results that we can get back whenever we do testing.
Dr. Powell, anything you'd like to add to that?
The thing is, with VUSs, the majority are downgraded. So what I mean by that is, say it's a VUS, once more information is available, we'll figure out that, hey, that was a normal variation, because we all have variations in our DNA. It's only about 10% that are upgraded to a positive result. So for the downgraded results, we usually, as soon as we get them, we will send out letters to our patients to say, hey, here's this new result. We have it templated. It's pretty easy. And if they want to see us, that's fine. But most of them are like, it gives them reassurance. For the positives, we bring them in for sure. We will do active follow-up because that's a really important change. But the other thing this brings up is, in non-white populations, the rates of VUSs are higher. And that is completely a function of our ability to interpret the test results. Because the more samples you have, the more people that get tested in a population, the better we get at interpreting, is this a positive result? Is this a VUS? Is this a negative result? So being from a minority community, there's already this disparity because your test results are more likely to be a VUS compared to someone of European ancestry. And the only way we're going to really fix this is if more people get tested. And
That's such great information as a patient, because that was something that was never told to me or my mom years later, to check back, or that things may downgrade or things may change. And so many of us, as you said, education is so important. So many of us, we're scared to check back because we're like, okay, maybe it's going to be even worse than ever. But knowing that it's 10% that's usually upgraded, that's such great information.
like Asha was saying, awareness is huge. And I do think I do research in this area, like in young Black women with breast cancer, and I've done it for probably the last 20 years or so. And we try to make it really easy for people to get tested. We provide the support, but we will send kits to their home. We will call them with results. And we were doing this, 20 years ago. And people are interested because at the end of the day, They didn't need to get the results to participate in the study, but they asked for the results. They had to have a genetic counseling appointment to get the results once we got the results back, and they did it. So, I think we need to go to the community.
I'll put this out to the whole panel, but how often would you recommend checking back?
I'm going to say there's no real gold standard, but I would say keep in touch every few years. I see patients back for a medical review about every 2 to 3 years. Again, it can be a quick appointment. If you have someone that you've already gone to, sometimes you don't even need to go in specifically. You can message through the patient portal and just say, hey, do you have any new information for me? That sometimes saves us time in some ways because we can answer you really quickly. Again, if there's something more involved, then we can say, hey, why don't you come and make an appointment? So that's where I think I don't know, Nikki might have some other guidance, but I would say every 2 to 3 years.
Yeah, I completely agree. Genetics is evolving exponentially, but we don't find new genes every year. It takes some time for those things to change and for panels to grow, for there to be enough evidence for us to say this gene is maybe causative or putting someone at a higher risk to develop cancer. I agree there's not really a gold standard. We say, particularly if there's a variance of uncertain significance, maybe every 1 to 2 years you can check back in to see if there are any updates or reclassifications, if there are any changes to your personal or family history, like if there's a new diagnosis of cancer that might warrant a reassessment of risk. It might also warrant whether or not you might qualify for high risk screening, regardless of your genetic test results. So that can also be helpful if there are any changes to your personal family. But generally speaking, I would say every 1 to 2 years or so.
Yeah, the other thing I would say is depending on the lab that you get tested at, many of the labs will send updates to classification to the testing provider. So the testing provider is actually responsible for sharing that information with the patient.
I also have seen firsthand the power of retesting. A very close friend of mine, she was diagnosed with breast cancer in 2011 in her 30s. And in 2021, her oncologist actually suggested that she retest. She had not retested for 10 years. She ended up testing positive for the TP53 gene, which predisposes you to many different types of cancers. And since then has gotten annual screening for that, which I think really has given her some peace of mind that she is doing everything that she can to reduce her risk of recurrence and monitor her health. So this is something that I am frequently talking to others about. What I see in my community, I live in Hawaii and we have a very strong Asian population here. But what I see frequently is that a lot of cases among young Asian women seem to be hereditary. And so I really agree with the note that Dr. Powell said about we need more data. We need more people to get tested, and the more people that we are able to get to enter this pool, the more information we'll have.
Now, again, we kind of said every few years is appropriate. However, what I would also say is the way we do testing since 2013 versus before 2013. And what happened in 2013 is the BRCA patent fell. So that led to panel testing, right? So we could do testing for multiple genes all at the same time. Before that, it was kind of sequential testing where you did BRCA1 and BRCA2, cost thousands of dollars. And then if there was a clinical indication, you could potentially get other genes. Oftentimes they wouldn't have been covered. So it was a much different clinical scenario pre-2013 versus post. So I would say for breast cancer patients, if you got tested before 2013, it makes it even more important to get retested. So I would say 2013, 2014, 2015, 2016, like we started changing over to panel testing, so doing multiple genes at the same time, but it took a while. Some people were still doing BRCA1 and BRCA2 testing. So if you kind of fell in that group, then you may not have gotten as comprehensive testing as you might today. Even with the technology that we have, you may not have gotten complete testing now compared to what you would have gotten back then.
Can I also just add that I think as a patient, this is where self-advocacy can be so incredibly valuable and important because I personally have not, my care team has not brought up retesting since my original genetic testing, which for me was way back in the initial days when I was diagnosed. Like I said earlier, I was pretty surprised that I didn't have any
Mhm.
markers or positive tests. I actually did have a couple of VUSs, but not related directly to breast cancer. And at the time, I was sort of laser focused because I had just been diagnosed. I met with a genetic counselor, and I did find that really helpful. He kind of broke down everything for me and explained how the process worked. But I did feel a little bit uncertain that I gave enough information. It all happened really quickly. I think it was within weeks of being diagnosed because they wanted me to do the genetic testing before I began treatment. And at that phase, I was just so completely underwater with one, processing my diagnosis to begin with, but also preparing for surgery, thinking through what the components of my treatment plan were going to be, figuring out how was I going to explain this to my workplace. There were just so many things swirling around that at the time I felt like I couldn't even really process this part of my care. But since then, I think I've really made it a priority to continue to ask questions, to request retesting from my care team. I haven't done it yet, but it's definitely on my list of things to discuss with my oncologist. I do think that this is something that patients can also be proactive about. When you go in for your follow up appointments or you're going in for your annual survivorship care appointments, make sure you ask and see if that's an option for you, if insurance will still cover it. If you had a family member who was diagnosed with cancer, whether it's the same type or a different type, use that as a trigger to just go back to those results and ask for another test.
So, we received a few questions from our audience. And so, just want to throw a couple of these out there to get your opinions on them. So, one of the questions we received was that breast cancer runs in both sides of my family, but my mom tested negative for breast cancer mutations. And they want to know when they should look into genetic testing, before or after they have children.
It's a great question. Just like how we discussed before, I think oftentimes people think breast cancer, mom's side of the family, and keep it there. But you get half of your genetic information from your mother and half from your father. So even though your mother's testing is clear potentially, still would recommend genetic testing for you. The timing of genetic testing really depends on a multitude of factors. Sometimes genetic testing can be used for family planning. If somebody does have a genetic predisposition to cancer, they might use that information to then do IVF and do further testing on their embryos. But generally speaking, when we think about the timing for testing, we might thinking of BRCA as an example. Screening starts as early as 25. And so potentially, starting getting testing around that time might be appropriate. And then for males, if they're BRCA positive, generally speaking, we recommend screening start at around 35. So around that time as well. But if family planning happens before that, then around that time too. So there's never really a right time per se, whenever's appropriate based off your familiar and personal needs.
And really, if it's a breast cancer predisposition, like Nikki said, if it's BRCA, we want to start screening you starting at age 25 with MRIs, right? Breast MRIs. The other thing I would add is on the father's side, if dad is willing to get tested, that's better than the daughter getting tested or the person asking the question. And if someone on dad's side, like if his sister or mom, like if they're living and had a diagnosis of cancer, again, those would be more informative family members. But again, it may not be feasible. So certainly wouldn't withhold testing from the individual, but those are other ways of kind of thinking about who might get tested.
Question that came in. It's all my paternal aunts had breast cancer. My mother so far has never been diagnosed. Do I have any sort of elevated genetic risk?
Nikki, do you want to take that one or do you want me to?
Yeah, we can kind of tag team this one. So, kind of the same principle, paternal risk still impacts you. And so, definitely, ideally, to test those paternal aunts first or your father. If not, then, genetic testing is definitely applicable to the patient themselves. Even if your mother has never been diagnosed, it's really coming from the dad's side of the family. So, still would be valuable to undergo genetic testing. It's actually interesting, really, for BRCA families when they're paternally inherited. Sometimes, they might be a little hidden in the family a little bit. And because maybe the father isn't impacted with cancer or anything like that. So, still always valuable to get genetic testing, even if it's coming from your dad's side of the family.
And each side of the family most times has to be evaluated separately. So you almost look at mom's side just as mom's side. Then you look at dad's side, just as dad's side. And like we had said before, half of women who inherit a BRCA mutation inherit it from their dad, right? Like, so we know that just the way population works. And all of our genes come in pairs, and that's how it works. Like, it's a flip of a coin, whether you pass it on. You have a pair of BRCA1 or BRCA2 or whatever inherited cancer gene. When you have children, you're either going to pass on the one with the if you have a mutation, the one with mutation or the normal one, right? That's where the 50-50 comes in. So that can be a man or a woman because men and women have BRCA mutations. So it really doesn't matter. It just depends on which side of the family the cancer is on.
And one of the last questions, and we may have touched on this a bit earlier, but just to come full circle to this question, do you recommend just testing for breast cancer or doing a full hereditary cancer screening panel? And so this person asks, if they do a full panel, is it still covered by insurance?
I would say it's largely family history dependent. In our clinic, oftentimes we kind of customize our panels based off our clinical expertise as well as patient preference. So, there's definitely a minimum that we would recommend, but if patients are interested in having additional information beyond just their personal or family history, that's usually offered to them as well. From my understanding, it shouldn't impact their eligibility for testing coverage. And so I think it kind of just depends what patients prefer. I've definitely had scenarios where I get an unexpected result where we go in with a family history of breast cancer and we're thinking we're going to get a breast cancer gene and we come back with something else. And now we know they're at a high risk for colon cancer, something completely unrelated that we weren't thinking about. So that doesn't happen all the time. It's pretty rare that happens, but it does happen. And so some people would like to just focus in on their personal or family history. Some people, especially those that are unaffected, oftentimes just want to kind of cover their bases and look at everything. And so it's kind of up to personal preference, but also sometimes providers might kind of help recommend certain panels over others.
So as we come to a conclusion of our discussion today, I would like to just go around and find out, what is one thing that you want everyone to remember about genetic testing? Asha, maybe you could start us off.
Yes. So for me, one of the biggest things is breaking the silence, especially for the minority communities that I'm a part of and that I help serve. In many of our communities, we don't talk about our health history, but the silence is literally killing us. And so that's something that um, I would love for those that are listening to take away. The silence is not protecting us, information is. So asking questions is an act of love for ourselves and for the generations that are coming after us.
And how about you? What's one thing that you would like everyone to remember about genetic testing?
I'd really love for people to remember that knowledge is power. There is so much value in knowing your family history and knowing as much as you can about your health and your diagnosis. I think minority communities, Asians especially, were known as the model minority. And with that comes a lot of expectation of perfectionism and putting the needs of others before our own. But similar to what Asha said, I think the best way that we can take care of our loved ones, of our community, is by taking care of ourselves first. And so don't underestimate the power of genetic testing and the information that it can give you to better take care of yourself and of others.
Nikki?
Yeah, one thing would be a great takeaway from this talk is that really genetics is super powerful and important, but it's not everything. It's one piece of the pie, and family history still matters, lifestyle still matters, screening still matters, getting mammograms, colonoscopies regularly are still important things. And again, most cancer just happens by chance. So oftentimes we won't find a genetic or a hereditary explanation for your diagnosis. So again, it's a piece of the puzzle, a very important part, but it's not everything.
So what I would say is genetic testing can save lives. And having practiced in this field for a long time, it is heartbreaking when we see a patient with stage 4 cancer whose cousin had been diagnosed with a BRCA mutation decades ago. Those are preventable. Just be aware of your family history, know about mutations in the family, share mutation information about the family, and genetic testing can save lives, either improve outcomes for patients with breast cancer as well as their at-risk family members. So just be your own advocate and know what this is and is it right for you.
So thank you so much, Asha, Ange, Dr. Powell, and Nikki, thank you for sharing your insights with us today. It has been so enlightening to hear from each of you and your phenomenal perspectives. We'd also like to thank Susan G. Komen for partnering with us on this webinar. If you'd like to dive deeper and find out more, tap into more resources on genetic counseling, please visit the Susan G. Komen website at the link seen on the screen. And if you're new to The Insiders, make sure you join our community at theinsiders.com, where you can get paid to tell your healthcare stories. And please be sure to follow us on social media. Thank you again for watching, and have a great day. Goodbye.